Welcome back to the deep dive. Today we're digging into a set of documents that, well, they paint a pretty stark picture of the English health system. And we're not just looking at things like wait times or funding. Those are symptoms, really. We're looking at what these sources are calling the tripartite crisis.
It's a crisis of structure, not just cash. I mean, the core argument here is that the Health and Social Care Act of 2012 didn't just tinker around the edges.
It rewrote the DNA of the NHS.
It absolutely did. And we're going to trace that rewrite today through three layers.
Right. So we've got the legal governance first, then the huge expansion of private services, and finally the direct impact on mental health.
And our mission, really, is to see how changing a single verb in a law can, down the line, lead to patients actually falling through the cracks.
It sounds so abstract, but let's start there with that one word. The documents are obsessed with this shift from provide to promote.
They are.
Does a single word really change how an entire health service operates?
Legally, it's everything. Under the original 1946 Act, the Secretary of State had a clear, direct duty to provide a health service.
So the buck stopped with them.
The buck stopped with them. It was a direct chain of command, direct liability. If something went wrong, the minister was responsible. The 2012 Act changed that duty to simply promoting a service.
Which sounds weaker. It creates what the documents call an accountability gap.
That's the perfect term for it. Because if the government is just a promoter, who actually owns the failure?
Right.
And this gets really serious when you bring in Article 2 of the European Convention on Human Rights, the right to life.
How so?
Well, if you have a death, say a suicide because there were no beds available, who is legally liable? In a system that's been fragmented into dozens of different commissioners and providers.
It's impossible to pin down. A legal maze.
Precisely. And that legal fuzziness opened the door for the second layer we're looking at, the economics.
This is the 49% rule.
This was the real engine of the change. Before 2012, NHS foundation trusts could earn almost nothing from private patients. The cap was lifted to 49%.
So a public hospital could suddenly get almost half its income from private work.
Overnight.
Now, you can see the argument, can't you? Doesn't that private money just flow back in and help the public side?
It's a logical assumption.
Yeah.
But the sources argue it creates a resource drain. And it's all down to what economists call cherry picking.
Ah, okay. So the private units don't take on the really complex, messy cases.
No. They focus on high-volume, low-risk, high-margin procedures. Think hip replacements, knee surgery.
The things that score well on QALY's quality-adjusted life years.
Exactly. It's a market model. You want the biggest QALY gain for the lowest cost. A hip replacement is profitable, the patient is happy, chronic mental health care is not.
It's risky, it's expensive, and it's slow. So the system starts to tilt.
It tilts toward the profitable hotel services, private rooms and scheduled surgeries, while the core NHS is left holding the bag for the most complex, most expensive patients.
And it's the same staff, isn't it?
Crucially, yes. You can't just create a new senior consultant. If your top surgeon is spending their afternoon doing private work to bring in revenue.
They aren't on the public ward dealing with an emergency.
It just redirects capacity. It doesn't create it.
Which brings us to the human cost. The third document zeroes in on mental health. This is where that legal fragmentation and the economic cherry picking really collide, isn't it?
It's the perfect storm. Mental health is high risk and low margin. So providers in this new market are trying to limit their financial exposure.
And that's where this referral bounce comes from.
Yes. A patient gets bounced between services. They're told they're too high risk for a community clinic, but then not sick enough for an emergency bed.
So they just fall into the gap between contracts.
They do. And because the system is so obsessed with metrics, you get this gaming of the system. The sources call it the hello nurse phenomenon.
That one really stood out. Is it literally just hiring someone to say hello?
Essentially, yes. To meet a target that says initial contact must be made within 4 hours, some providers would hire staff to just greet the patient.
It stops the clock.
It stops the clock on the spreadsheet, but no clinical care happens. It satisfies the logic of the market, but it completely fails the patient.
And the data is clear. Suicide rates don't correlate with how well these boxes are ticked. They correlate with real things, like staff turnover and social deprivation.
We've built a system that's brilliant at measuring the cost of a life year, but the sources argue it's really struggling to value life itself.
That seems to be the final synthesis then. The constitutional change enabled the economic shift,
which in turn drove the clinical fragmentation.
So we went from a single system designed to, provide a safety net to a fragmented market designed to measure efficiency.
And that leaves us with this powerful tension. Quality of life, a new knee, a private room that has become a commodity you can buy.
But the right to life.
That's a constitutional guarantee.
Yeah.
And it's finding it very, very hard to survive in a marketplace.
Which really begs the question, if the system is designed to promote a market instead of provide safety, who is actually looking out for the patient? Thanks for diving in with us.
See you next time.